let's just talk about what does guidance actually mean to a doctor, and what are its limitations in practicality or in practice?
Wonderful. Well, the guidelines are a set of recommendations, and I think you emphasized this also in your introduction, that these are a set of recommendations. These are not, as you can imagine, there are no guidelines that can cover every scenario, and every patient is almost a little bit different than the next one that we meet. So these are a set of recommendations, and typically they are designed to be multidisciplinary. They're usually initiated by the American College of Cardiology and the American Heart Association, and they are usually endorsed by a number of other societies like Society of Cardiac Angiography and Intervention, Society for Vascular Surgery, and many others. So we tend to be very collaborative in nature as it relates to these guidelines. And what we do in these guidelines is that we try to synthesize the literature, synthesize the data, and give some guidance, some recommendation in regards to the diagnosis, treatment, and follow-up of a certain diagnosis. In this situation, peripheral artery disease. We have guidelines for coronary artery disease. We have guidelines for carotid disease. So there are separate guidelines. And the reason they're separate, because these can be very extensive. They could be very time consuming. And the point of this is that there is a document that is multidisciplinary, that is data driven, and that is synthesized all the information that's out there and has made some kind of a formal recommendation in a form of a grade. And the grading is important. So the guidelines have two types of grading. One is a grading that is based on numerical grading, 1, 2, and 3. And 2 has a 2A and a 2B. And then there is another grading that is based on the evidence that is available out there. And that's A, B, and CE or COE. And I will explain what that means. So when we make these recommendations, we tend to give evidence, and level A evidence means that there's a lot of randomized trials. There is a lot of data and randomized trials comparing one evidence versus a placebo to show their superiority. When there is no evidence, we say CE. CE stands for expert's opinion. And expert opinion means that there is not a lot of data, but the experts who are writing the guidelines are making these recommendations. So that's a weaker recommendation than, let's say, a level A. And then from a numerical standpoint, a level 1 means that is the highest recommendation. So when we say, for example, that a patient with ulcers and gangrene should have a ABI, this is a level 1. That means that every patient should have this. And those are the ones that are the most evidence-based. Similarly, a level 3 is where we say you shouldn't do this. So for example, we say that if a patient is asymptomatic, if the patient doesn't have any symptoms, you shouldn't go and do a bypass. That's a level 3. Those are the hard stop. You shouldn't be doing that. Everything else in the middle is give and take. You know, we empower the doctors to kind of evaluate the patients and make a personalized decision based on the guidelines recommendation and based on the data in regards to what approach they want to take. So that would be a 2A or a 2B. So 1, 2A, 2B, and then level 3.
The recommendations are simply just that. But is there any accountability for these doctors in following the guidelines or deviating from those guidelines?
There is not a formal penalty, to be honest with you, but sometimes, as you know, in the hospitals, we have Q&A and quality meetings where we discuss different conditions. So let's say we had a physician that was doing too many amputations and was not doing revascularization. One of the pieces of evidence we would use in our QIMM meetings, our quality meetings, would be the guidelines. We would bring the guidelines to say, Dr. McNicholas, you know, you are you're doing a lot of amputations and you're not doing revascularization, look, the guideline says that this is a class 1 that you should be doing revascularization for patients with ulcer and gangrene. Why are you not doing that? So it could provide that kind of evidence in those kind of circumstances. But as you know, not all hospitals are created equal, and not necessarily there are very robust QIMM meetings at every single hospital. So there is no formal kind of accountability, if you will, based on the guidelines, unfortunately. Sometimes the guidelines can also be brought to the courts. So let's say a physician does something that's very inappropriate, and then the attorneys can bring the guideline and say, hey, Dr. Shishehbor, you were supposed to do a revascularization for this patient before amputation, or you were supposed to do an ABI before you amputate this patient. Why didn't you do it? Look at the guideline. The guideline says a level 1 evidence for you to do an ABI for any patient who has an ulcer or gangrene. Why didn't you do it? So they can bring this, in addition to experts that they bring to the court, they can bring the guideline and kind of hold physicians accountable because they were not following the evidence. Where the data is very clear is with the level 1 and level 3. When you get to the middle, is there is a lot of room for wiggle, and it's harder to make a case. But with level 1 and level 3, there's a lot of evidence and clarity and consensus, and that's where the guidelines can be very powerful.
Right. So the guidelines are there and they can be held up, is what you're saying, in not only court, but also in the form of public opinion, such as the media. Right. And so the doctor in those cases really does have to make sure that they have a good case to explain why they're not following, especially the level 1 recommendations.
That's exactly right. That's exactly right.
Was there anything in terms of the process or any of the guidelines that that really surprised you? Maybe a guideline that was or was not offered in this set?
Yeah, so that's the challenge of the guidelines. As a matter of fact, I've had many mentors that actually refused to participate in the guidelines. As you know, I was one of the writing committee members for the guidelines, and I participated because I think it's important to have that variety of voices represented in the guidelines. We want to make sure that it's a multi-dimensional, multi-societal, and that we are hearing all kinds of voices. And as you know, I'm very passionate about limb salvage and P.A.D. So we wanted to make sure we have all kinds of voices within the guidelines, and that's why I participated. But the surprises are, one is that sometimes the guidelines are outdated. So as you can imagine, by the time you put all these data together, you go through all these meetings. I mean, this took 2 years. And by the time you get it published, there's been 10 trials that have been presented. And unfortunately, we get the paper, we get the guidelines, but it's behind. So the latest and the greatest is not available in the guidelines. So that's one criticism that comes out. Sometimes if you have conditions, and we deal with that in the vascular disease, where there is a paucity of data. In coronary disease and in heart disease, there is a lot of data. As you know, we do trials with 20,000 patients, 30,000 patients, 50,000 patients. So there's a lot of data in the realm of heart disease. So the guidelines can be very robust because there's a lot of data. When you're dealing with the diseases like P.A.D., where there has not been a lot of trials, they can be a challenge because the guidelines tend to be conservative when there is no data. But just because there's no data doesn't mean that we don't have patients, and we have to treat our patients. And that's where I find the guidelines a little bit limited, because when there is no data, the guidelines have a hard time making a recommendation because they like to be data driven, but that leaves our patients behind because we don't make recommendations, and that bothers me because we still have to treat the patients, even though we don't have data. It'd be nice to have data, but just because we don't have data, it doesn't mean we don't have to take care of those patients. So those are some of the areas where I think that the guidelines fall short. And then lastly, sometimes the guidelines can become challenging because as I said, these guidelines are multi-societal, and it's a balance. And sometimes in that balance, I think we can leave some patients behind. And it's like the Washington D.C. With our government. Sometimes in finding that balance, we leave some people behind, and that can happen with the guidelines. That's why I loved how you started the introduction. These are a set of recommendations. This is not hard rules, and that we still need the doctors and the healthcare providers and the entire team to be very dynamic and take a personalized approach to each patient. Every patient is his own person, and we should be very dynamic and very personalized in treating each patient, using the data and the information as a support in making the decision as to what's right and what should be done in regards to diagnosis and treatment and follow-up.
I love what you're saying in terms of we do need an individualized approach, because there are those limitations in the guidelines, and we do have to take some of them with a grain of salt. But there still are those guidelines that have that level 1 evidence that we do need to take more seriously and are a little bit more definitive, even today, even 2 years later after you've started, correct?
100%. And this is what we call the low-hanging fruits. Because as you said in your introduction, let's not get into the political part or the things that are not clear. Even if we stuck to the level 1, many of these are not being done. And you mentioned a couple of them, and we can get into it. Simple things like, listen, if you have a patient with ulcers and gangrene, you need to get diagnostic evaluation. You need to do an ultrasound. You need to do an ABI. We know that there are thousands of patients undergoing major amputation, and they don't even get a simple ABI or an ultrasound. So I think we should put our energy into the low-hanging things that are level 1, that everybody has agreed by evidence that these are things that need to be done routinely, such as medical therapy, diagnostic testing, revascularization, those kind of things. Everybody has agreed that they are level 1, and I think we have a lot of work to do. And I am grateful to you and your entire team for taking this on and educating our patients and our communities. Let's at least get to the level 1. Once we're done with the level 1, then we can worry about the other stuff that are not as clear.